Hi there and welcome back. Let's review one of the most common impairment that you will be encountering in your daily underwriting routine, and that's chronic obstructive pulmonary or lung disease. COPD, that's how you would normally see. We'll get into the data we have, what are the reasons or the causes, signs and symptoms, how do we diagnose, treat, frequently encountered complications, and the bottom line underwriting. So let's start with chronic obstructive pulmonary disease. COPD is a group of lung diseases that block airflow and make it difficult to breathe. Most people with COPD have a combination of chronic bronchitis and emphysema. Though one form may predominate, most are smokers or former smokers or have occupational exposures to damaging inhaled substances. Some individuals with COPD also develop an asthmatic component to their pulmonary disease. So chronic bronchitis and emphysema. So let's talk about chronic bronchitis. Chronic bronchitis is a pulmonary condition characterized by chronic or greater than 2 years excess secretion of mucus along the tracheobronchial tree, resulting in impaired oxygen transport and obstruction of airflow into and out of the lung. And you will notice here normal FVC with decreased FEV1. Chronic bronchitis is inflammation of the lining of the bronchial tubes which carry air to and from the air sacs called alveoli of the lungs. It is characterized by daily cough and mucus production. Emphysema. Let's talk about emphysema. Emphysema is a condition in which the alveoli at the end of the smallest air passages, that is bronchioles of the lungs, are destroyed as a result of damaging exposure to cigarette smoke and other irritating gases and particulate matter. Emphysema is a condition characterized by irreversible, I repeat, irreversible loss of lung elasticity due to the destruction of the elastic tissue of the lung. Emphysema is characterized by air trapping and obstruction of airflow out of the lung. So here you will notice increased FVC with decreased FEV1. What are the statistics out there? Very common, more than 3 million cases per year, and is the third leading cause of death in the United States. Much more common over the age of 40, and that is probably because sustained exposure to smoke or other damaging inhaled substances greatly accelerates the normal decline in lung elasticity associated with aging. Another data suggests rate of progression from early to advanced disease is variable and not clearly predictable, but number of pulmonary medications, the frequency of illness or hospitalizations, compliance with the therapy, continued exposure to smoke or damaging inhaled substances can aid in determining the degree of risk involved. And that's what typically you will see in your manuals. Another data indicates death in older individuals with COPD is typically due to acute respiratory failure, pneumonia, lung cancer, cardiac disease, or pulmonary embolism. Increased morbidity and mortality results from recurrent pulmonary infections, progressive debility, and eventually cor pulmonale or right-sided heart failure related to chronic pulmonary hypertension. Lots of data out there. What are the causes? Smoking, chronic asthma, occupational exposure, secondhand smoke, air pollution, and alpha 1 antitrypsin deficiency are listed as frequently encountered causes that contributes to the COPD. What are the signs and symptoms? It includes chest tightness, wheezing, chronic cough for 3 months in each of 2 successive years, shortness of breath, frequent respiratory infections, having to clear your throat first thing in the morning due to the excess mucus in your lungs, lack of energy, swelling in ankles, feet or legs, and sometimes unintended weight loss in later stages. So, how do we diagnose? The distinction between chronic bronchitis with irreversible airway obstruction and emphysema may be difficult to make. They often coexist. Treatment is similar, and the prognosis depends upon the clinical behavior of the disease and lab parameters rather than the specific disease title or the nomenclature or the label. COPD may occur in smokers with sufficient sputum production to enable a clinical diagnosis of chronic bronchitis to be made and without objective evidence of emphysema. You will notice in clinical practice, and those of you who have many doctors as your friends, you will hear from them also that in clinical practice a diagnosis of COPD is made when there is irreversible airway obstruction which may be caused by either of these diseases irrespective of the relative contribution of each. Okay. Another aspect in this process is the fact that asthma may eventually progress to chronic obstruction, and although it is not included as a cause of COPD, in a few patients the diagnostic distinction between the COPD and asthma is sometimes impossible. Well, don't worry, you are not the doctors. You will see the diagnosis in the medical records that you may end up ordering to underwrite any case. Okay, so enough on the diagnosis. Let's move on to the treatment. How do we treat COPD? Smoking cessation, inhaled and or oral bronchodilators, steroids, pulmonary rehabilitation, oxygen and surgery that may include bulectomy, lung volume reduction, and sometimes even lung transplant. Okay. Frequently encountered complications include AFib and atrial tachy, cor pulmonale, respiratory failure, lung cancer, pulmonary hypertension, as well as depression. So that precisely covers the chronic obstructive pulmonary disease. And bottom line, how do we underwrite? Well, you will see frequently ordering medical records because of you are seeing COPD and other red flags in the medical records as you screen the application and or on the pyramid exam, because sometimes you may not see on the application but these things may be admitted by the customer on the pyramid exam, and you may end up ordering the medical records. Follow your underwriting manual and the internal company specifics and take that route. Let's take a quick break here and see you soon. Take care. Bye now.